So we have the foot right now. So all we have to do again, just follow everything through what they said. You're also looking for bony prominences, the ecchymosis, joint effusion, everything else that's actually abnormal. Okay. So again, bony prominences. So assuming that we have this patient standing up, I'm just going to go ahead and identify the landmarks as we go through. Okay, looking at the lateral side, okay, you got your lateral malleolus, okay. Down here is your calcaneus, okay. You have your talus up here, okay. This is the base of the fifth metatarsal head right there. It's the most prominent bone that you feel. If you're running your finger right here and you start to come to that bump, that's your fifth metatarsal head. And this is where your Jones fracture is. If you have Senior Chief Duran, he's going to actually ask that. Okay. So Jones fracture is the fracture at the base of the fifth. Okay. Now, next I'm going to go ahead and roll this leg right here. So go ahead, if you want to stand up right here. Okay. So you have your medial malleolus. Okay. You got your arch. Okay. So in arches we have 3 different arches. You got your normal arch. You got your pes cavus, which is a high arch. You got pes planus, which is a low arch. Okay. And so those are all the 3 arches that we have. You got the ball of the foot here too as well, just in case, first MTP, okay, and you got your Achilles tendon right here, okay, and then what's really things that you want to note are the types of toes. You got your claw toes, you got your hammer toes, and then you got the hallux valgus. So hallux valgus, again, going back to the first MTP, is your bunion. So that's actually going lateral deviation of the first MTP, okay. That's where your bunion is going to be. Claw toe is just pretty much, just imagine a claw that's actually going this way, and then you get hammer toe, or hammer toe, which is just pretty much like a mallet, so it just pretty much goes this way. Okay, so that's your hammer toe. Okay, next is things that we have to find out at the back, viewing it from behind. Okay, so assuming that we're actually, think of valgus and varus. Okay, so again, if the foot from behind is tilting this way, outward. Okay, this is your pes valgus. Okay, if it's going that way, again, you have to view this from behind. If it's turning inward, as the patient is standing up on the ground, it is pes varus. Okay, so inward varus. Okay. No, you're good. You're good. You're good. And then again, this is done by standing up. But as you are explaining to instructors, sometimes they don't even require it. But if they do, just know that outward is valgus, inward is varus. Good. Now, here comes the structures that you have to know. And I may have to, anyone of you guys have pens? No. Okay. If you don't have, okay, here we go. So,
No, I do.
You do? Okay. If you don't mind if I draw on your leg?
No, that's
okay. Here's the cheesy part again. Things that are very important, and I have to use this. Okay, this is your calcaneus. I mean, this is your fibula, okay? So, we'll label it as fibula. This is your calcaneus. 3 structures. You got your calcaneofibular ligament, okay? Just combine this word, calcaneofibular. So this is that structure right here. You got your anterior talofibular ligament. So talus is right here underneath this guy, okay? So you got your anterior. So if you got an anterior, you got a posterior, most likely. So if you have an anterior talus, talofibular, so this is the talus, like I said, and it's connecting here to the fibula, okay? Anterior. So this is anterior, talofibular. And then you also have, if you have an anterior, you have a posterior. Posterior, talo, again, this is the talus, and then connecting to the fibula. There we go. Easy day. So if you watch this video, just go over this, you guys are set. So like I said, posterior, anterior, calcaneofibular. And acronyms, you got your ATFL, your PTFL, and then of course this is your CFL. That's all you need to know. In the medial side right here, you have this thing called the deltoid ligament. There's a lot of names, and thank goodness they're not going over the names. We could stay here all day for that too as well. This section here is your deltoid ligament, okay? And that's the reason why it's really strong, hence the word deltoid, because it's really built to not break, okay? These are the 3 structures that would most likely break during an accident when you actually invert your foot, okay? All right. So we're done with this. So we got all the prominences. I'm sorry, let's go back here. So you also have your navicular, which is right here, and you'll use this later on. Navicular is pretty much like after you feel the divot, the first like a few centimeters from here, is your navicular. You'll use this later on when you do your figure 8 of your ankle swelling measurement. Okay. So next is going to be the easier parts, which is your movement. So you got your movements. So you got dorsiflexion, which is going up, plantar flexion, which is going down. You got eversion, letter E, taking it out. You got inversion, taking it in. There we go. Good. And then next is going to be toe movements. So individually, you could isolate if you want, one by one, or you could just let them, if there's nothing wrong with the patient and you want to see in general motion, go ahead and curl everything forward and extend everything backwards. Good. There's not much abduction, adduction going on here, so there's not much muscles do that here. Okay. So next is fighting it. So doing the muscle strength. So put your hand here, resist dorsiflexion, and then resist plantar flexion, resist eversion that way, and then resist inversion. There we go, good. And then resist toe flexion, so you're fighting it, good. And then resist toe extensions, good. Perfect. So we have those things done. The only thing we have to do right now is special tests. So we got 4. We're almost done. Hang in there. Okay. So with this anterior drawers test, so it could be done sitting down and laying down, well, however the patient is presenting himself. I'll grab this section and then grab the lower half, and I'm going to apply what you call an anterior movement. So it would be pretty much this way. Okay, a positive sign would be this section giving in to your anterior talofibular ligament. So ATFL is actually broken when you have a positive anterior drawers test. Next is going to be your inversion stress test. We call it the Taylor tilt. So inversion is pretty much just taking it as simple as it is, flick it, okay? And then you would see a significant gap at this section when you flick it, and that's testing for your CFL, or your calcaneofibular ligament. Go ahead and take a seat for me, sir. Okay. Next is going to be, oh yeah, later on we'll go over that real quick. Okay, now you got your Thompson test. We'll be doing that later on. Let's do the last one, second to the last. Is your tib-fib squeeze while the patient's sitting down right here. It's easily done. Just go ahead and interlock your fingers behind, and then just squeeze. 1, 2, 3. Easy day. You don't have to hold down here or squeeze this way. It doesn't matter. Or if you do, you can put your thigh right here and then squeeze. Okay. A positive sign would be pain at the distal aspect of your, or a little bit higher than the distal aspect of your syndesmosis. Okay. High ankle sprain, syndesmosis sprain. Okay. That's what I forgot to identify earlier, just in case if you, going back, you have your tibia and fibula has what you call your syndesmosis, okay, or your interosseous membrane right here, okay, and it's going to be prone to high ankle sprain if the pain is actually located somewhere right about here in this section right here. Okay, again, you got Mason-Knoll fracture, just in case if it's going to be asked by Chief Strickland, is the separation of the fibular head off from the fibula itself. Goes that way. That's a Mason-Knoll fracture, and that's also a high ankle sprain. If you do this, it creates a bowstring effect, and you could easily see that thing just bow out. Or if you do it here, it actually could bow out from here too as well. That's your tib-fib squeeze. Lastly is your Thompson test, thump. Earlier we had Thomas test. Don't get confused. Thomas test is testing for your hip flexion. Thumps, and think of a P as the plantar. So testing this section. Go ahead and lay down on your chest. There we go. So, Thompson test, squeezing the calf section. So, as you could just relax. What happens here is that if I do this, and the patient doesn't plantar flex, what the patient's doing right now is plantar flexing. If it doesn't plantar flex, and if I do this, and it's just solidly nothing, that means Achilles tendon got ruptured. Okay. So that's the final test for the lower extremity. We're almost done. Next is your leg length discrepancy or your limb measurement. So go ahead and lay down your back. Assuming that I have a tape measure right now. I want to make sure that the legs are actually symmetrical in length. So the best thing to do here before, again, take your tape measure. The best thing to do is actually bend, relax, bend the patient all the way in. Good. And then pull out. And then just pull a little bit. There we go. It lines up everything. It lines up the pelvis. Get your tape measure. Plant it at your ASIS, right about here. Okay. Grab your tape measure. Run it all the way down to your medial malleolus, right about here. and then take the measurement and then transfer it right here. Hopefully that they're actually symmetrical. A pathologic one would be 2.54 centimeters, almost like 1 inch. So aside from that, 1 centimeter is fine. It's normal. People have leg lengths that aren't that bad. Okay, next is the figure 8 measurement. So this is done by actually starting here at the navicular area, okay, and then you're going to come down medially. I don't have the tape measure, but just in case, just explain it. It's just like a figure 8. Comes right here and goes inward, and then comes at the base of the foot, and then wraps around, touching the base of the fifth, and then coming back up, and then pass through the lateral to the medial malleolus, and then pass to the lateral malleolus, and then take the value. So let's go over it again. So it starts 1 down here, under the foot, pass to the fifth, going up, come by this way, and then ends up right here, and then get the value. That's for your figure 8 measurement. You're using that to see once the patient comes back with like a big swollen joint effusion right here, and you want to measure that for comparison for healing. Okay, so that concludes your special tests. And any questions? Email me or email HM1Aaron and HM2TJ. All right. So good luck, guys.